She is a professor of oncology at Roswell Park, a pediatric oncologist, and the chair of at the Oishi Children's Cancer Center and Blood Disorders Program. She earned her medical degree at the University of Buffalo and did her residency in pediatrics at the University of Pennsylvania Children's Hospital of Philadelphia. She is the Waldemar Kaminsky Endowed Chair of Pediatrics and has multiple leadership roles at the University of Buffalo, including Division Chief of Pediatric Hem-Onc and Division Chief of the Department of Pediatrics at the medical school. She specializes in leukemia and lymphoma in children and adolescents with a specific focus on Hodgkin and ALL. She is the chair of the NCI-supported Children Oncology Group, a committee on Hodgkin since 2011, and she currently serves as the Scientific Advisory Board member and Adolescent and Young Adult Initiative Committee leader for the Lymphoma Research Foundation. She is an amazing speaker and has been an inspiration for me, and I'm really looking forward to hearing her speak. Kara.
All right, thank you so much, Anne, for such a wonderful, kind introduction, and especially the opportunity to participate in this really terrific forum. I'm so pleased to co-present with Dr. Nancy Bartlett, who is an outstanding lymphoma investigator and clinician. It's collaborations such as Women in Lymphoma not only bring lymphoma investigators from all over the world together, but it also helps to facilitate bringing pediatric oncologists and medical oncologists together, which, as we will demonstrate hopefully tonight, that is so important in the care of our adolescent young adults with Hodgkin lymphoma. Our plan for this evening is to share an overview of the major pediatric and adult approaches for treatment, discuss how we are now working more collaboratively together, and then review some of the specific issues that need to be considered in developing optimal management approaches for adolescents and young adults with Hodgkin lymphoma. So I just want to make sure, can you all see my slides? Okay, great, all right. So on the first slide, this represents the distribution of new cases by age group using
Kara,
data.
You're not in the presentation mode. It's in the, there's like 20 slides on the screen.
Oh, okay.
Yeah.
Okay. Huh. That is strange. Okay. My screen is showing up that way. It's not here.
Is everyone, mine looks like the whole slide deck. Yes, I have the whole slide deck. Kara, if you can't switch it, I can also pull up slides.
Sure. Is that working or not?
Not yet.
Not yet. Sorry about that. Let me just try it again. Oh, wait, you know what I think I could do? Just these, sorry about that. I guess you still can't see it. You know what, I think maybe if you don't mind then, Anne, if you wanna show the slide on your screen and I'll tell you when to advance.
Okay.
I just can't seem to get this set up.
All right.
I think with the last minute switch from the laptop to the computer.
Oh, sorry.
That's okay.
All right, let me share my screen here. Does that work?
Yep. If you can go to the next slide, please. Okay. Okay, so what I was saying is that this slide represents data on the number of new cases by age group using data from the US SEER registry. And as you can clearly see, the age group with the most number of cases are patients that are ages 20 to 34. Specific to pediatrics, Hodgkin lymphoma is the most common type of cancer in the adolescent age group, yet it represents just 12% of the total new diagnoses of Hodgkin lymphoma each year. So if you can go to the next slide. So, over the last 3 decades or so, the management of Hodgkin lymphoma has really diverged considerably between pediatric and adult programs. And what that means is that if you're an 18-year-old and presents to a pediatric oncologist, they're, often will get a very different treatment recommendation compared to an 18-year-old presenting to a medical oncology practice. And the reasons for this are quite varied. On the pediatric side, many of the patients are treated in an academic or hospital-based program, and therefore many are enrolled on clinical trials, often in much greater rates than on the adult side. One of the major issues is the impact of survivorship research, especially as these pediatric patients can generally look forward to many decades of life ahead of them. But then on the flip side, there is often delayed access to investigational agents in the pediatric side, as early phase clinical trials usually limit age of entry to 18 and older. So if you can go to the next slide. So in terms of some of the factors that drive the pediatric management, one is just the recognition of just the high survival rates. Again, this is data from US. It shows the percentage of deaths among patients with Hodgkin lymphoma by age group. And you can see, particularly for the pediatric Hodgkin lymphoma patients, the death rate is extremely low. It's just 0.9%. So really high survival rates have been a hallmark of the disease in this age group. You can go to the next slide. But the real issue that's driven many of the treatment regimens for pediatric Hodgkin has been the recognition that the late effects of therapy can really significantly impact the long-term survival. This is data from the Childhood Cancer Survivor Study, which is a very large cohort study. There's several of these cohort studies that have been done around the world, but this one has contributed much knowledge to our understanding of long-term effects of treatment. In an analysis of the Hodgkin lymphoma survivors, this was done by Sharon Castellino, who's a member of our Children's Oncology Group Pediatric Hodgkin Working Committee. She reported that the Hodgkin survivors had a significantly inferior overall survival compared to the US population, as you can see clearly in the figure on the top. But when you look specifically at the causes of death, deaths from Hodgkin lymphoma tend to plateau by about 15 years post-treatment. But deaths from other causes, primarily premature cardiovascular events and second cancers, rise and don't show any sign of plateau. So on the next slide, if you could show, move to the next one. And, it's not just mortality, but also many of the therapies that have been used historically have significant morbidity and lead to chronic health conditions which significantly impair quality of life. Again, in an analysis from the Childhood Cancer Survivor Study, which compared Hodgkin lymphoma survivors to their siblings, you can see quite clearly that the relative risk of having a chronic health condition is significantly elevated. The risk of having a serious health condition, a grade 3 or 4, 10-fold increase, and the likelihood of having multiple conditions is almost a 9-fold increased relative risk. So this recognition has really been what's been driving the more contemporary management in the pediatric side. So if you can go to the next slide. So the strategy that has evolved on the pediatric side is to optimize the balance between maintaining high overall survival, yet reducing treatment-related toxicity. And this has been evaluated through response-adapted regimens. So if you can go to the next slide. So I'm going to just briefly review some of the highlights of the pediatric approaches, providing some examples from more contemporary studies. I did want to call everyone's attention to the fact that we do now have pediatric Hodgkin lymphoma guidelines through the NCCN, the National Comprehensive Cancer Network. For many, many years, these only existed for adult cancers, but there's been a big initiative to develop guidelines for some of the major pediatric cancers, including Hodgkin lymphoma. And so I'll just highlight a few examples from these guidelines. If you can go to the next slide. The one thing, though, I do want to emphasize is that I think some of the major differences you'll see from listening to the overview of the pediatric regimens and when you hear Nancy describe the adult regimens is that pediatric regimens tend to emphasize less radiotherapy for lower risk patients, including patients with bulky disease, but yet more selective use of radiotherapy for patients with high risk disease. So that is kind of a major difference than from the adult approaches. So if you can go to the next slide. So I'm going to first start with some studies that have been performed by the Children's Oncology Group. The AHOD-0031 is the largest contemporary reported study to date, and this was for patients with intermediate risk Hodgkin lymphoma. I will say one of the challenges in comparing studies is that the definitions of the risk groups do vary quite considerably. And intermediate risk, which is probably somewhat closest to early unfavorable. But this study also included patients with stage 3A and 4A, which would have been considered advanced stage in trials among the adults. In this trial, we utilized a regimen called ABV-EPC. You can see the drugs on the side. This regimen is somewhat intermediate in intensity between the ABVD and BIACOP. It is a dose-intensive regimen administered every 21 days. And the purpose of this study was to compare the standard approach, which is 4 cycles of chemotherapy with radiotherapy to involve fields, with a response-adapted approach, where patients that were rapid early responders after 2 cycles, and then who had an adequate response at the end of chemotherapy, did not receive radiotherapy, even patients with bulky disease. Whereas slow responders received additional chemotherapy augmentation with a regimen called DECA, which had shown efficacy in relapse trials, and then involved field radiotherapy. Of note, this study employed a response definition using CT. It was an anatomic reduction, as this was really the standard at the time that the study was done. So if you can go to the next slide. So some of the highlights of this trial, this study was reported in JCO in 2014 by Deborah Friedman. The study was associated with a very high event-free survival at 4 years, 85%, overall survival of 97.8%. And considering that there were stage 3 and 4 patients that were enrolled, this is really quite good results. Importantly, the study showed that rapid early responders did have a superior outcome with a 4-year event-free survival of 87% versus 77% for the slow responders, and also a significantly improved overall survival, 98.5 versus 95.3. So response made a difference in outcome, and many studies have subsequently showed the same thing. The other important observation is that radiotherapy did not improve outcome in patients that were rapid early responders. So this suggests that it can be omitted, again, even in patients with bulky disease. But the chemotherapy intensification for the slow responders, we did not see a significant difference. And it was probably because the DECA regimen was not sufficient for this group that is relatively more chemo insensitive. I do want to call your attention to a recent secondary analysis from this trial, reported this as a paper that was just very recently accepted in Blood and is available in Early View, led by Lisa Gelino-Roth, that reports on the 10-year cumulative incidence of second cancers in this cohort. This was an important area to address, especially since the regimen included etoposide and still a good percentage of the patients receive radiotherapy. Importantly, the second leukemia rate was only 0.2%, and that's really in the range of what has been observed in other regimens that don't include etoposide. And yet the second cancer, which almost all occurred in patients that have received radiotherapy, that number is expected to continue to climb given the relative short latency for this period to date. So it does underscore the need to further develop regimens that can further reduce the use of radiotherapy. So if you can go to the next slide. So the high-risk study, AHOD-0831, which I was very privileged to lead in the Children's Oncology Group, was a regimen for really high-risk patients. So we selectively targeted the patients with 3B and 4B disease, as these had shown an inferior results in previous trials. They received an augmented form of the ABV-EPC, which had additional cyclophosphamide. Here, early response was assessed by PET scan, as this was now used, and the cutoff for positive was a Deauville score of 3. Patients that were rapid responders got additional cycles of this regimen, and radiotherapy only to bulky areas of disease. where patients that were slow were augmented with ifosfamide vinorelbine, which had shown activity in our relapse trials, and received radiotherapy to initial bulky sites as well as slow responding sites of disease. So if you can go to the next slide. And the results are shown here. And, again, I remind you, this was for 3B and 4B patients. So, patients that really don't do very well. And yet with that, the 5-year event-free survival was 79.1%, overall survival 95%. We did not see a statistical significant difference between the rapid and the slow, probably a function of the numbers, but there is a trend towards improvement with the rapid responding patients. I think importantly, this represented a step forward in pediatric trials in that we reduced radiation use for the rapid responders only to their bulky disease instead of with all involved sites. We still have room to go on that, but it did represent a step forward in trying to reduce the radiotherapy exposure for this group of patients. So if you can go to the next slide. So building upon that, the Children's Oncology Group recently completed another large phase 3 trial. This was led by Sharon Castellino, and it compared our standard ABV-EPC regimen with a new regimen that replaced the bleomycin with brentuximab vedotin and reduced one of the doses of vincristine. So in some ways, a bit similar to the Echelon 1 type of design. This study, in addition to the chemotherapy change, also continued to build on the reduced radiotherapy use, and that the rapid responders only got it to bulky sites, whereas the slow got it also to the slow responding sites. The study completed accrual, and we're just waiting for results for this study to mature. So if you can go to the next slide. So those are just some of the highlights of the Children's Oncology Group approaches. In Europe, the Euronet PHL is the Collaborative Pediatric Hodgkin Lymphoma Network, and this group has developed collaborative trials for patients under the age of 18. The regimens have evolved from really great results on trials that were run by the German Pediatric Hodgkin Research Group. And thus far, the Euronet PHL has completed the C1 study, hoping to see results reported out on that study this year, and have just recently completed accrual to the C2 trial. These studies, again, I think highlighting the challenges of comparing the risk groups. The TG1 is the low risk, TG2 intermediate, TG3 high risk. And again, the definitions do vary from what we've used in COG and vary from what the adult group. So it does, again, limit our ability to compare head to head. The Euronet PHL has shared the same interest of trying to further reduce radiotherapy usage. And they use it a little bit different design with a different backbone. The OEPA is for induction, and you can see the details of the regimen. Patients that have a negative PET and a significant reduction on CT do not receive radiotherapy. For the intermediate and high-risk groups, they receive consolidation with COPDAC, and radiotherapy is also reduced depending on PET and volume criteria. So, the European group has really taken lead in significantly reducing the amount of radiotherapy in pediatric Hodgkin groups. And again, we look forward to seeing their results later this year. If you can go to the next slide. So that's kind of a high-level view of the pediatric regimens. What I really wanted to shift now and talk a bit about why are we coming together to discuss adolescent and young adult oncology. And this is really an age group in the cancer field that has been highlighted as a group for which we really do need to do more and to do better. The adolescent and young adults, which are defined depending on where you live in the world. So in the US, the NCI defines them as ages 15 to 39. Where in Europe, they're often defined as 15 to 24, and across the world there are some differences. But in general, these are patients that are in their late teens, early 20s, sometimes early 30s. And this is an age group that represents the interface or the transition between the more typical pediatric cancers, such as leukemias, which are shown in the dark green bars, to the more adult type of cancers, such as breast cancer, which are shown in the light green bars. In addition, there are several cancer types that are more prevalent within this age group, such as thyroid cancer, shown in orange, germ cell tumors, shown in pink, and lymphomas, which is shown in blue. So that's why it's so important for us to be looking at this group specifically. The AYA oncology has received a lot of attention because overall, this group has not experienced the same gains in survival as our younger pediatric patients and our older adult patients. So initiatives to try to help, improve survival are really needed. And as I'll show you, it's complex. It's more than just treatment. And in order for us, we need to understand all of these factors in order to develop the optimal treatment approach. So if you can go to the next slide. So within pediatrics, I think for many years we just kind of lumped all pediatric patients, under age 18 or 21, depending on the center or the clinical trial. But we got thinking within our group, are they all the same? Is age prognostic specifically within the pediatric population? So given that we had within the children's oncology group completed accrual to 3 large trials, had a lot of clinical data, we took advantage of this to do secondary data analysis to be able to better define outcomes, specifically in the adolescent population. So this secondary data analysis that was led by Justine Kahn with senior leadership by Sharon Castellino included almost 2,000 patients who had been enrolled on the 0031, the 0831, and then a low-risk study, the 0431. This cohort was over half the patients, 54%, were 15 and older, median age of 14.6. As expected, 81% had nodular sclerosis and histology. They were, as expected, it was more the older patients that had this type of histology. There was no difference in the presence of bulky disease or early versus advanced stage by age. If you can go to the next slide. So multivariable modeling was performed to look at whether age was a prognostic factor, and indeed it was. As shown here, the hazard ratio for relapse was significantly elevated in the 15 and up with the nodular sclerosis histology, and was especially elevated, 3.7, in patients with mixed cellular histology. So, to us, that really emphasized the needs that, maybe some of the great outcomes we were seeing in our pediatric studies were being driven, a lot by our younger patients, and that we needed to look more closely at the older adolescents and consider collaborative efforts with our adult colleagues to try to improve upon those outcomes. So if you can go to the next slide. So what I want to just very briefly at a high level highlight are some of the potential contributing factors, to some of the disparate outcomes that we see in the adolescent young adult cohort. These include the biology, is the biology the same in a patient that's 10 with Hodgkin lymphoma versus somebody who's 18? As well as host differences. We know that there's differential susceptibility to some of the late effects of therapy, such as breast cancers, which seem to affect more women receiving radiotherapy in their adolescent or in their 20s. Treatment differences also contribute to the different outcomes. Long-term organ toxicities, and then cancer care delivery factors, access to care. Young adults, in the United States, many patients in their 20s will age out of their parents' health insurance. I know that's less of an issue around the world, but it does impact access to care for many patients in this age group within the United States. So I'm just going to give again a few examples of each of these domains just to hopefully get you thinking and maybe getting some ideas of projects that you can do and other ways that we can collaborate to be able to do better for this cohort. So if you can go to the next slide. So, from a biology standpoint, there's very little we know about why there are differences across the age span. This slide summarizes the distribution of the Hodgkin lymphoma subtypes by age. And, we have this big peak of nodular sclerosis type in individuals in the adolescent young adult age group. Why is it, why does this happen during this age group? And then the other types, tend to increase over the lifespan. So on the next slide, I'm just going to highlight one collaborative project that we've been working on to try to understand some of these age-related differences. The British Columbia group, David Scott and Christian Steidel, and others from the great group there have done a lot of work looking at gene expression profiling as a prognostic marker for Hodgkin lymphoma. And they had reported a 23 gene signature that was prognostic of outcome in adults with advanced stage disease. So we took this signature and applied it to one of our COG patient cohorts. This was predominantly an adolescent age cohort. And as shown on the bottom panel on the left, the signature was not prognostic at all. In fact, it was the complete opposite. Many of the genes associated with a poor prognosis in adults were associated with a good prognosis in our pediatric cohort and vice versa. So we then did additional work and developed really a new signature that showed that it was different cellular subtypes that varied in their prognostic importance, suggesting that there might be kind of more immune or microenvironment differences in the younger patients compared to those that were much older. So this is still ongoing work, progress we're planning to validate in additional studies. But I think it just highlights the opportunity that, there can be additional biomarker analysis across different age groups to help us hopefully understand, the impact across the lifespan. So if you can go to the next slide. From a treatment standpoint, I mentioned earlier that one of the challenges we have on the pediatric side is delayed access to some of the novel investigational agents, which are really beginning to shift the landscape of care in treatment of patients with Hodgkin lymphoma. And really one of the, kind of shocking statistics that I recently came across was a report that found that the median time from first in adult to first in pediatric is 5.7 years. So that means that a 17-year-old with Hodgkin lymphoma has to wait almost 6 years to have access to a drug that a 19-year-old can get. So there has been a big push in the United States to lower the age of entry for early phase clinical trials to 12, to also include patients 12 and up in some of the large phase 3 clinical trials. And it's through these initiatives we should hopefully be able to provide earlier access to our adolescent patients. Okay, if you can go to the next slide. As I mentioned, there's a lot of cancer care delivery factors that also do contribute to this AYA survival gap. Everything from insurance, as I mentioned before, clinical trial access, healthcare disparities, which unfortunately in the US is still a major concern. And I'll just highlight 2 examples of research that have been looking to try to shed some light on these factors. So if you can go to the next slide. One is in the area of health disparities. And again, I'm highlighting some work from Justine Kahn. On the left side is an analysis that was done of the SEER registry data, looking at improvements in survival across different cohorts with Hodgkin lymphoma. And the good news is that each of the cohorts is showing improvement in survival, but it isn't evenly distributed. So as you can see, the adolescent young adults, did not have as big of an improvement as the children did. And especially the Black adolescent young adults all did not have, they had the smallest gains in survival. And that translates to, for a white AYA patient, 5-year survival, 96.4 versus only 92% for the Blacks. And in another analysis that we did through the Children's Oncology group with that secondary data analysis, we looked at post-relapse survival among different race and ethnic cohorts. Again, predominantly adolescent patients, and you can see that the non-Hispanic whites had the highest overall survival, with really a marked drop-off in survival, particularly for our non-Hispanic Black patients. So any of the efforts we do really have to take into account, ensuring that there's equal access for all of these patients. Okay, if you can go to the next slide. The other major area is in clinical trial access, and what this slide demonstrates on the black line, it shows that the number of treatment trial accruals that is adjusted for the number of cancers, the cancer ratio. And so what you see is there's initial peak in pediatrics, so a lot of patients enrolled there, and then really a dearth of clinical trial accruals in the adolescent young adult age group, our peak Hodgkin lymphoma age group. And then it goes back up again in older adults. The investigators then did a second analysis where they looked at the 14 cancers with peak prevalence in adolescent young adults. So that's the little dotted purple line there. And then specifically looking at clinical trial accruals, and that, among those cancer types, you can see again that of those cancer types, big peak in pediatrics, big peak later in adults, but it really drops off in the AYA age group. So if you could move to the next slide. So this is just my last slide, and what I want to really just try to get you all thinking about is that I think the way forward is to kind of come together and identify ways that we can better understand these factors and develop more collaborative treatment approaches. We're beginning to do that, and Nancy will share a few examples, but I think that's really what's needed to help to shift the needle for this group of patients. So just lastly, my last slide is just acknowledgements. This work could not have been done without really great colleagues from all over. On the left side are members of the Children's Oncology Group, Hodgkin Lymphoma. I have many great colleagues and collaborators in the adult cooperative groups in North America, as well as through the pediatric Euronet, and then at St. Jude. So thanks very much, and I will turn it over to Nancy now to provide the adult perspective.
Great. Thank you so much, Kara, for an outstanding talk. A lot of really thought-provoking issues there. And hopefully we'll have a little bit of time to get to some questions. But I'd like to next introduce Dr. Nancy Bartlett, who is a professor of medicine in the Department of Medicine at Washington University and holds the Komen Chair in Medical Oncology. She received her BS and MS in chemical engineering from Stanford and MIT, and then got her MD at Washington University. She completed internal medicine at University of California, San Francisco, where she was a chief resident, and then completed her medical oncology training at Stanford. She is currently the vice chair of the Alliance Lymphoma Committee and the US Cooperative Group, which is responsible for developing national clinical trials, and is a member of the NCI Lymphoma Steering Committee, as well as a member of the Scientific Advisory Board for the Lymphoma Research Foundation. Her clinical research focuses on the development of clinical trials and evaluating new therapies for lymphoma. She has mentored many fellows and young faculty, both at Washington University and I think around the country. She's the chair of the Siteman Cancer Center Quality Assurance and Safety Monitoring Committee. And she is a force of nature when it comes to recruiting patients to clinical trials and really moving the field forward. I mean, she's really an inspiration to all of us in the adult lymphoma field. So Nancy.
Thank you very much. Let's see. Oh, there we go. All right, let me do full screen. All right, can everyone see?
Yes,
we have the full screen. Oh, perfect. Okay. All right. Well, thank you very much, Anne, for again that extremely nice introduction. And just want to thank you for the invitation to speak today, and want to thank Kara for just an outstanding presentation, and also for spearheading the efforts to try and formalize the collaborations between the Children's Oncology Group and the adult NCTN groups in the AYA space. Truly a Herculean effort. Hard enough to get one group to agree on anything, as Anne well knows, much less getting 4 groups and the NCI to agree on anything. So hopefully we can move forward with that, despite the difficulty in getting everyone together. And just as opposed to Kara, where I think they really do spend a lot of time thinking about AYA, I think it's because of the Children's Oncology Group that the adults have started spending more time thinking about AYA. Quite honestly, we have not done anything special for our AYA patients in terms of developing specific approaches, but I would say it's the late effects in our AYA population that has really motivated the kind of trials that we've done over the last several years to try and decrease those late effects. So as I said, our recent generation of randomized trials for stage 1 and 2 adult Hodgkin lymphoma have all been asking the question whether we can use interim PET to eliminate radiation in most patients. So as you can see, there are a number of studies that have been done, and I'm just going to kind of try and go through these very quickly to let you know what the answer was with each of these phase 3 trials. But before we do that, I just wanted to spend one slide, and Kara has already really made a very nice introduction to this about why we've been trying to eliminate radiation as our major focus for the last 2 decades. And on the left panel, I've been using this figure for about 10 years, and it is still very relevant, telling us that we cure about 90% of patients with early stage Hodgkin's using combined modality therapy. But starting at about 10 years and really kind of taking off in the 15 to 20 year range, we start seeing a very high incidence of second cancers, as well as a high incidence of cardiovascular disease. And the middle panel shows the outcome of 40-year follow-up from a Netherlands cohort of second cancers after receiving treatment for Hodgkin lymphoma. And so these are the control population here, and these are the Hodgkin's patients. And this was over almost 35 years, extending from 1965 to 2000. And you can see during that time frame, even though during this 89 to 2000, we were definitely using lower doses, we were using trimmer fields, there appears to be right now no change in the incidence of second malignancies. I'm hoping the Netherlands will give us the 2000 to 2020 cohort, because I think more changes have happened during that time frame. So hopefully at some point they'll update this data. And then I also, in the right panel here, just want to speak for a minute about breast cancer, which I think is something that we worry really most about in our young women. So the highest risk for breast cancer are in those Hodgkin's patients treated between the ages of 10 and 30. And there isn't really a documented decrease in breast cancer with lower radiation therapy doses. There has been a decrease in the risk as they've trimmed the fields down, especially getting rid of the axillary fields. And interestingly, there's been an increased risk of breast cancer with our new chemotherapy approaches, because in the old days when we used nitrogen mustard and lots of Cytoxan and alkylators, that many patients became sterile. And so they had low hormone levels, and there was a decreased risk of breast cancer. And so we fixed one problem and caused another problem. And again, these issues are most relevant to our AYA population, which are the patients who are the most vulnerable to these toxicities and also obviously have the most to lose. So those graphs I know speak for themselves, but for me, I think it's always helpful just to kind of go through a couple of patients really quickly. I've been here for almost 30 years at WashU, which has awarded me the opportunity to follow a group of patients and start seeing many of these second cancers and cardiovascular problems. So this is a relatively regular occurrence for me now, and is always just the reason I continue to work in this field. When you see these patients, you know that we still have a lot of work to do. So this was a woman who was diagnosed at 23 with non-bulky early stage Hodgkin's, had 4 cycles of ABVD. That was pre-PET days. And so she had a PR by CT and had involved field radiotherapy to the bilateral neck and the mediastinum, had 3 children over 5 years, about starting 4 years after her treatment, had 1 negative breast biopsy. In 2016, had a negative stress test, presented with chest pain in 2017, was found to have ischemia and stenosis on a cath and had a 2-vessel cabbage. 6 days post-op, was having angina again and required 4 drug-eluting stents. And then 3 years after that, she had another cath for persistent chest pain and already has severe in-stent restenosis. So obviously this story is not over for her, but is just a constant source of stress and, a total quality of life changer. On the right panel is a 19-year-old woman with bulky stage 2 Hodgkin lymphoma who received Stanford 5 chemotherapy back in 2000, and then involved field radiotherapy. She was having annual mammograms alternating with breast MRIs from 2007, so starting 7 years after her radiation through 2019. She had a negative breast biopsy in 2012. She had her first child in 2020, required IVF for that pregnancy. And while she was breastfeeding, her OBGYN palpated a left breast mass, which turned out to be a stage 1 poorly differentiated infiltrating ductal carcinoma with lymphovascular invasion. She underwent bilateral mastectomy and is currently on adjuvant chemotherapy, taking care of a 1-year-old. So these stories, hopefully this story will have a happy ending, but we've seen that not be the case. So I just want to run through the 3 non-bulky trials and then a couple of the bulky trials and spend most of the time on the early stage patients, because I think that's where we really are seeing the most trouble in terms of the late effects. So the RAPID trial was the first one to ask this question about whether we can use an interim PET to decrease the number of patients who receive radiation. So everyone got 3 cycles of ABVD. 75% of patients were PET negative and went on to be randomized to observation versus involved field radiotherapy. And to just remember that 25% of the patients were PET positive and went on with 1 more cycle of ABVD, and all of those patients received radiation. So here's the PFS curve on the left. And as you can see, both groups of patients did quite well. 3-year PFS of 95% versus 91%. If you look at the patients who actually received radiation versus those who did not, according to protocol, the difference was even greater. And this was a statistically significant difference, no difference in overall survival. So this was a bit disappointing, the fact that there was still a statistically significant difference, even though we used the PET to determine who was not going to receive radiation. And then here's the PFS for the PET positive patients who just went on to receive 1 more cycle of ABVD and then radiation. They also did very well. It's this kind of dot dash line right here. And they had a 3-year PFS of 87%. This was a recent relook at the RAPID data by the Nuke Med physicians, a recent publication in JCO where they went back and looked at the patients according to their Deauville score or their 5-point score. And as you can see from this, the patients who had 1 to 4 all did very well. And it was the patients who had a 5 when they before they went on to the radiation who did not do as well. So just mentioning this to kind of keep in mind when we see another study, the EORTC-H10 study, where they recommend changing the chemotherapy when you have a positive PET after 2 or 3 cycles of ABVD, that maybe we only need to change the chemo in the 5-point scale score 5 patients and not in the 3 and 4 patients. So then this was the next study that the German HODGKIN study group did, and it's a little hard for me to understand. Usually they tend to have more aggressive therapies for their patients, but this actually was the HD16 study. And despite knowing that there was a difference with 3 cycles of ABVD with or without radiation, they went down to 2 in the favorable patients, which was a group that was fairly similar to the RAPID study. And patients who were PET negative went on to observation versus involved field radiotherapy. And you can see that, this trial was a failure, that 2 cycles of ABVD by itself is not enough. The 5-year PFS was 86% versus 93% for the radiation. So I don't think anyone has picked up this approach for early stage patients. So this is the study that really, I think, guides most folks across the world in treating these patients, which is the EORTC-H10 trial. And they had about 40% of the patients had favorable characteristics and 60% were unfavorable. And just to kind of briefly go through this, although I'm sure most of you are familiar with this, there was a standard of care arm for the favorable patients, which was 3 cycles of ABVD followed by involved nodal radiation. Then the experimental arm, if you had a negative PET after 2 cycles, you got 2 more cycles of ABVD. If you had a positive PET, you got 2 cycles of escalated BIACOP and involved nodal radiation. For the unfavorable patients, it was 4 ABVD plus involved nodal radiation for the standard of care arm, and the experimental arm, they now got, if they had a negative PET, 6 cycles of ABVD. If they were positive, 2 cycles of escalated BICOP plus involved nodal radiation. So in terms of the results, this is for the patients who were in the favorable group and were PET negative after 2 cycles of ABVD. And you can see that there was quite a dramatic difference in the PFS, 99%, which I don't think we've ever seen a result like this in early stage Hodgkin with just the use of 3 cycles of ABVD plus involved nodal radiation versus 87% for the chemo alone. But as we have seen over and over again, no difference in the overall survival. In the unfavorable group, interestingly, who were PET negative, there was no statistically significant difference. So 92% versus 89.6% for 4 cycles of ABVD plus radiation versus 6 cycles of ABVD, and no difference in overall survival in this group as well. So kind of interesting to see that the patients who had unfavorable Hodgkin's and had a negative PET actually did better than the favorable Hodgkin's with a negative PET in the chemo-only arm. And so there's been a lot of discussion about whether these patients got 6, the favorable patients got 4 cycles of chemo, whether there would be any benefit to giving more chemo to the unfavorable patients. And then here are the patients who were PET positive. And in this, they combined the favorable and unfavorable patients who were PET positive. And both arms, the patients went on, if they were PET positive, to receive 2 cycles of escalated BICOP and radiation in the experimental arm. And then they compared that against the standard arm, which was 4 cycles of ABVD plus radiation. And as you can see, there was a highly statistically significant difference in favor of changing the chemotherapy before giving the radiation, 90 versus 77. And even in this one, a trend, still not quite statistically significant, even in the overall survival. But based on that data we saw from RAPID with Barrington, it would be nice if these guys would go back, I haven't seen that, and look at the outcomes according to the Deauville score and see if it's really the 5s that are driving the need to go to escalated BICOP, because I think a lot of us are, even though it's only 2 cycles and the patients probably tolerate it okay, I'm always a bit resistant to this approach, quite honestly. And it would be nice to know if you could just stick with the same chemo if you were a 3 or a 4 and only move if you were a 5. And then just the last trial for the, this is not a randomized trial looking at the radiation question. RAPHA was a randomized trial looking at the bleomycin question. So PET negative got 4 cycles of ABVD versus 4 cycles of AVD. And this was for advanced stage patients, which were defined mostly as 3 and 4, but also for stage 2 patients who either had bulky disease or B symptoms. And there was a fairly large cohort in this group. And as you can see, the 3-year PFS, and these are the PET negative patients, no radiation, bulky 91.5%. So a really good outcome. And this looks very similar to the chemo alone arm for the unfavorable EORTC patients. So that was like 89.6 versus 91%. So I think we can tell patients who have bulky or advanced stage Hodgkin lymphoma, if they have a negative PET after 2 cycles of ABVD and just go on to continued AVD, that they're going to have about a 90% chance of being cured with no radiation. And so in summary, our attempts to eliminate radiation in early stage Hodgkin based on a negative interim PET. In the favorable patients, I think you would have to conclude that it was a failure because there is still a 6 to 12% decrease in PFS with elimination of radiation, and both in the RAPID and in the EORTC. And that's almost exactly what we had in the old days when we weren't using PET. And when we were just using CT to decide if someone had, a complete remission. And there's, but again, no difference in the overall survival. And then I would say the attempt with the interim PET was successful in the unfavorable patients, that there is no difference in outcome when you eliminate radiation in patients who are interim PET negative. And then I always look at the PET positive patients. probably is a failure because it's 20 to 25% of patients who still need to receive radiation. And so again, I think there's room for improvement in that PET positive group in terms of trying to figure out if there's anything we can do besides radiation. So what are we going to do next? So new approaches for these patients with early stage to try and close this PFS gap without radiation. And the obvious way to try and do that is either adding or substituting the new drugs that I think you guys heard a bit about on one of the previous forums. And so first want to just talk for a minute about this small phase 2 study that was run by Dr. Abramson, which I just think that this is a very interesting approach. So these patients all received BV, so brentuximab vedotin in combination with Adrian DTIC, and they eliminated not only the bleo, but also the vinblastine. So the patients were not getting double vinca alkaloids, significantly decreasing the risk of peripheral neuropathy and also decreasing the risk of febrile neutropenia. So in this study, there was no febrile neutropenia and patients were not getting growth factors, which as you'll see in the advanced stage, you do need to use if you're using BV plus AVD, and that there was no grade 3 or 4 peripheral neuropathy. And as you can see so far, again, very early follow-up, but no relapses in these 34 patients. And so Kara touched on this a bit already, but just wanted to go through this. So this is the first attempt in early stage Hodgkin's for sort of a joint AYA protocol between COG and the adult NCTN groups. And this is being run by COG. And this is not approved yet, still lots of layers. So we're not sure this will move forward, but we are hopeful, still in development. And that in this proposed trial that I put the favorable and the unfavorable together because I think there's only, and correct me if I'm wrong, Kara, but I think there's only one difference in those two groups. Initially I had 2 slides, but I think it's all on one slide. So everyone gets 2 cycles of ABVD. If their PET is negative, they get randomized to either 2 cycles of ABVD if they're in the favorable group or 4 cycles of ABVD if they're in the unfavorable group. And versus 4 cycles for everyone, favorable or unfavorable, to BV plus a PD-1 inhibitor. If they're PET positive, which will be probably 15 to 20% of patients, they are randomized to the standard from the H10 trial, which was 2 cycles of BIACOP plus radiation versus 4 cycles of BV PD-1 inhibitor plus radiation. So a lot of compromises had to be made here. I will tell you that the statisticians at the NCI like to design trials. And so I think we all have things that we think could be better with this, but hopefully we can move this forward. And sort of the downsides of this is that there's still going to be your PET positive patients receiving radiation, and that the standard arm here is still one where we know that somewhere between 10 and 15% of patients on this arm are going to relapse. So in advanced stage, what advances have been made in the last several years with our clinical trials? As Kara pointed out, we don't really ask the radiation question in advanced stage patients. We don't use radiation in advanced stage patients. And our goals for these patients are trying, again, still to increase the cure rates without increased toxicity. So we already went through the RATHL study, and we know now that we can eliminate bleomycin in patients who have a negative interim PET, which is about 85% of the patients, and a 3-year PFS of 82.6% in that study. ELISA study, which I think has really not taken hold in the US, but I think is still widely used in Europe, where they actually start with 2 cycles of BIACOP and then de-escalate to ABVD if they have a negative PET. And they have a pretty remarkable 5-year PFS of 92% with this approach. I have concern with this approach for especially our AYA population, because if you have a positive PET, then you go on to a total of 6 cycles of escalated BIACOP, which would basically be sterilizing in men and women. And if, again, 6 cycles of escalated BIACOP, you're looking at the 3% chance of AML or MDS. So, you know, I I don't know. I'd like to hear other people's opinion about whether they do this in any of the AYA patients, but we have not. And so where are we going with the advanced stage patients? Really trying to do what Kara has done in the PEDS group, is to incorporate these new agents. So this is the Echelon 1 trial, which was ABVD versus AAVD. And you guys have probably seen these results many times. This was the initial publication at 2 years with 82% versus 77% for ABVD. P-value statistically significant, no difference in overall survival at this time, and the overall survival has not been published again since that time. But the 5-year update was just recently shown at ASH, and I think will be published sometime in the next 6 months. 82% versus 75%. So that difference is holding up over time. And then just in the most recent publication, the ASH abstract, and in this upcoming publication will be the first time we'll see the comparison of the second malignancies in these two arms and also the fertility. And, you know, all of this is just descriptive, that these were not meant to be, you know, you can't put a p-value on these, but numerically there were fewer second malignancies and more pregnancies in the AAVD arm. So I think what we can say is that adding brentuximab does not increase infertility, nor does it increase the number of second malignancies. And then just wanted to talk very briefly about 2 other very small studies. This is nivolumab plus AVD. And with this, the early, you know, the first time this was published was at like 9 months, and it looked like it was, you know, right up here where they all sit. But now at about 2 years, it's 83%, and which is, looks very similar to what we just saw for the BV-AVD. And so unclear whether the PD-1 inhibitors will, you know, move the needle at all for the early stage patients. And I'll get to the randomized trial in just a second. And then this is Pembro plus AVD, again, a very small study, only 30 patients. And there was a mixture of stage 3 and 4 and stage 2, but you know, so far, again, one of those curves where they haven't seen any relapses, which looks, and this is kind of interesting because this is only 3 doses of Pembro followed by 6 cycles of AVD, as opposed to the Nivo AVD, which is 12 doses of Nivo given on day 1 and 15 of each cycle. So this is the trial, the AYA COG NCTN collaborative trial for stage 3 and 4 Hodgkin, the S1826, and hopefully many of you in the States are participating in this study. So patients are randomized to nivolumab plus AVD for 6 cycles versus brentuximab plus AVD for 6 cycles. And then they are allowed to have radiation, which I suspect was a compromise put in for the pediatric group, because I don't think this is really something we do in adults. But if they have a positive PET at the end of treatment, or a 4 or 5 or greater than 2.5 centimeter lesion, if you declared at randomization that you were going to radiate the patient, then you are allowed to give consolidative radiation. I'll be curious to see at the end whether how many of the adults went on to get radiation versus the peds. And then where are we time-wise, Anne? Are we out? 5 o'clock?
Yeah, it's about, yeah.
Okay,
Finish
one more
up.
minute.
Take your time.
I got one more
take your
slide.
time.
So this was a paper written by Tara Henderson in Pediatrics with collaboration from Andy Evans and some of the other adult ECOG investigators, and looking retrospectively at a COG study versus an ECOG study, and looking specifically at the patients between 17 and 21 treated on those 2 trials, and looking at the outcomes. So it's definitely very difficult to make this comparison because the treatments were very different and the eligibility criteria, so many more early stage patients on the COG trial and advanced stage patients. But if you look at these sort of, you know, at face value, that there was no difference in the failure-free survival or the overall survival in the stage 1 and 2 patients with these 2 approaches. But there was an improved failure-free survival and overall survival with the COG approach in the stage 3 and 4 patients. They do give more radiation, hard to know. And there was just this one bizarre finding, which was in the in the ECOG study that patients in the 17 to 21 year range actually did worse than patients in the same study that were 22 to 44. So I think a lot of, Kara showed that the different determinants for the AYA, and you just never know which one of those determinants is at work here. But having us all treat patients on the same protocol will help us sort of determine or make some determinations about why this might happen. So just my final thoughts. Again, I think we need to continue to prioritize the collaborative efforts between COG and the adult groups in this AYA population. For the early stage patients, if we use the current trials, then at least half of patients would still receive radiation therapy, those who have in the favorable group or a PET negative, and all the PET positive patients. Alternatively, you can accept the lower PFS with the need to salvage more patients. And so our potential path forward in this group is to try and incorporate these new agents so that fewer patients are PET positive. In the advanced stage, kind of the same thing. I'm not sure what we'll see with the Nivo BV. It seems like maybe we're going to improve the PFS by about 5%. So it seems like we're probably going to need something else there, maybe both of them together. Will be the next step, the BV and the Nivo plus AVD. And then just specific for the AYA, I think the adults definitely need to take listen to the pediatricians in terms of the survivorship. I don't know what you think about that, Anne, but other than just, the fact that my patients have the same doctor for 30 years, which is very unusual. So we're really all about survivorship and ordering all the tests. But that's not probably the case for most AYA patients who move to a different city, don't ever see an oncologist, go to some primary who doesn't know anything about it. So it's, I think there's a lot of work to be done there too. All right, you want to take it back. Thank you very much. That was very fun to do with Kara.
Thank you, Nancy. That was really fantastic. And I think you just frame things in such a clear way and highlight the issues. And I think there's so many similarities. I mean, it's really the same group of goals, I think, between pediatric and adults. We want to get rid of radiation. We want to improve overall survival. We want to maintain, very high cure rates. So it's just interesting to see the two side by side. We don't have too much time for questions, but do have a question from Kate Cisnarski. What do you think of the HD17 from presented at EHA, which included patients from 18, but let's assume we're going to go lower. And they started with escalated BIACOP and used PET to guide whether RT can be omitted in early unfavorable. I mean, would you ever consider using, I think you sort of answered this question, and I feel very similarly. We just don't use escalated BIACOP in this patient population, but just your thoughts and Kara's thoughts on.
Yeah, and I don't know, when you see that data, I agree with Kate that when you look at the paper, it's hard to say why we don't do that, because 2 cycles of BIACOP, the women won't be sterile, the men probably will, so they'll all have to do sperm banking before they get any chemotherapy, which is not that big of a deal, but still, needs to be done, and somebody's paying to keep that stored and all those kind of issues. But it's been so long since I've used it, but in the old days, it really is much more toxic. Having all that prednisone for 10 days and the procarbazine, and how to work in the growth factors when they're on procarbazine for 10 days, and patients feel like garbage. And so, it's only 2 cycles, you could say that, and then move on. But I guess until I see an overall survival difference, that I haven't been doing it in the advanced stage or the early stage, but I know that's unusual. When you talk to our friends across the world, the Canadians, the Europeans, I think they do that based on the data. So I just have a hard time with the BIACOP, but.
Yeah, I think the other is that it's a hard regimen to give in AYAs that want to still, they don't want to come to clinic 3 days in a row. They don't want to be, have the febrile neutropenia risk. So again, that's another trade-off that needs to be considered for this age group.
Yeah.
So I think we're running a little bit out of time, but would give a plug for our session next week, where we're going to present a bunch of different cases with international opinions. So I think we may get to some of the questions that came up in the chat, and I think we'll learn a lot from each other just to see pragmatically how do people approach cases, early stage ones where you might use BV-AVD versus ABVD. So stay tuned for that. I'd like to thank our sponsors again, MSD and Roche, and also our chair, Professor Judith Trotman. But most of all, I'd really like to thank Kara Kelly and Nancy Bartlett, who gave, I mean, two of you, couldn't feel better about the team sort of leading this forward for AYA patients in the US. Really inspiring, not only as investigators, but as role models for all of us. So thank you so much.
Thanks, Anne.
Thank you. Thanks so much.